Top Med Talk.
Welcome to Top Med Talk. I'm Desiree Chappell, your host, and I'm joined by our editor-in-chief and chair of this year's EBPOM World Congress of Perioperative Medicine, Monty Mythen. Hello, Monty.
Hi, Desiree. Great to see you. But what a shame that we're not in person. We really thought, sorry to get a downer on straight away, we really thought a year on from pulling this off a year ago, that we would be in some form of hybrid meeting this year. But maybe we're getting a lot closer. But it's great. The World Congress has started. It's going really, really well. We've got a fantastic turnout again. Everyone's been very generous with their time. Yeah. Good to see you as a co-chair, Desiree. So I'm not the chair. I'm a co-chair.
Our co-chair. There's several of us, right? That we're not the only two. There's a team that it always takes to pull off something like this. But sure to be a fantastic meeting. This is just day one, Monty, of EBPOM, of the World Congress, and so a lot more fabulous content to look forward to. Now, Monty, we always kind of want to give a shout out to our industry partners because we really cannot do this without their support. We are able to offer this virtual meeting at very reduced prices and free for underserved countries, right?
So we tried to keep the ticket price down as far as we can. Now, last year, we went out there fairly bravely and we gave all tickets away at no additional charge as a result of our industry sponsorship. And we asked people to donate money to a charity that we named, which we're still supporting, which is the African Perioperative Research Group, and that went really well. But this year, we've gone back to the as affordable, low price as possible ticket, starting at, we did it $25 for the youngsters and poster presenters. But the really important thing is that sponsorship plus the people who bought tickets flips over to make the tickets free, open access to the whole of the low middle income countries in the world. I mean, all those people who signed up, it's great to have you here. Tell your friends. Yes. The content will still be available on demand.
Yeah, absolutely. Thank you. Well, today is Medtronic Day. They are a generous sponsor for us, and thank you very much to them. And so we have some fabulous podcasts. We have a lunchtime session about total IV anesthesia and a great conversation coming up later today about video laryngoscopy. But right now, I'm so pleased to introduce our guest, Dr. Sam Ajizian from Medtronic. He is a Chief Medical Officer for Patient Monitoring, and we are going to be talking about connected care. Hi, Sam. How are you?
Hi, Desiree. Hi, Monty. Thanks so much for having me. It's great to be a small part of the World Congress and happy to be on with you both today.
Well, it's fantastic that you could join us, Sam. I know we've been trying to actually get this conversation going for a little while. And so we have been talking a lot about connected care, especially throughout COVID. It really kind of accelerated this. But before we kind of dive into that, I'd love to hear more about your background and for you to share a little bit more about yourself.
Oh, sure. Thanks. So briefly, I'm a pediatric intensivist by training. I practiced most of my career in academic medicine at Wake Forest University here in North Carolina, where I still live. I have been with Medtronic now for a little over 6 years. And my current role is Chief Medical Officer for Patient Monitoring and Director of Global Clinical Research and Med Science for Patient Monitoring and our Respiratory Interventions business.
Fantastic. Well, Sam, tell us a little bit more about connected care and really what that means.
Yeah, it's great. I think if you sat 10 of us down in a room and asked what connected care meant, we'd get 10 different things. And that's really important as we embark on a new field of medicine, which is connecting patients via the cloud into the EMR to their providers with actionable data that doesn't increase workflow. That's kind of what the high level view of connected care is. It's doing things earlier, it's doing things better, and making workflow easier. If you think about the reality that's coming in the next 20 years, and COVID gave us a snapshot of this, we're seeing higher acuity in inpatients year after year after year. Unfortunately, we're seeing less people going into critical care, which is understandable because we have high rates of burnout because of the workflow and the emotional demands of the job. And that includes our nursing colleagues as well. So we have rising acuity, which is going to lead to the creation of ICU towers for hospitals. And that's going to shift the care of patients that are in general med surg wards now, potentially to home. And we have to come up with monitoring and monitoring solutions and algorithms that can keep them safe, connect them to meaningful caregivers, and action earlier in the process. So connected care is a combination of the right tech to monitor the patient that's human factor friendly and easy to use. That tech has to connect to the cloud. It has to be able to be used to develop predictive, preventive, and supportive algorithms to empower healthcare workers to get to the patient earlier than ever before. So, we think about early warning scores, and Monty and I are old enough to remember when those didn't exist. What I like to think about are earlier warning scores, or even earlier warning scores, where we're going to get information on let's say a patient that got a new knee. Their parameters are suggestive of an infection starting in 24 or 48 hours. And that data is looked at by the team in a very high level, easy to understand and digest way, and an action can be made early. So we're hoping that continuous connected care creates the platform, the network, and the software to keep patients out of the hospital, keep them more well than ever, and couple them to meaningful preventive actions for their caregivers.
We've been seeing this coming for a while now. And, the youngsters coming through would say, you're making this whole medicine thing a bit complicated with all that paper and the way you do it. Look at what we do over here. And suddenly it seems as though this is accelerated and being accepted very, very rapidly over the COVID period. Even if I look at my own family practitioner, there was a reluctance to engage in the opportunity of sharing all my lab results via the apps that were there already. And suddenly it's to kind of, turn the app on, use it. And mixed in with that has been the incentives to stay away from hospital, if at all possible. The idea that you might self-monitor yourself with an oximeter to work out if you're deteriorating, if you did have a cold. And then the really key bit that's just happened in the UK is you have to prove you've been double vaccinated. And the way you prove you've been double vaccinated is to switch on your National Health Service app, insert your unique identifier, which you have in the UK, and then you can say, look, I can go to the football match because I've got, and that's so motivating to people. It's brilliant.
It is brilliant. And I think you're exactly right. We're the late adopters. The folks that are leading critical care and anesthesia departments around the world are all, in our age group. And you could argue that we're late adopters for tech like that. I agree. I've learned a great deal from my residents over the years. And a lot of that is app-based iPhone things that I never would have found myself. So I think we've got to leverage that, folks. We've got to realize that there's already profound and complex and highly effective cell phone platforms around the world. And that's the currency that we use in our daily lives. So it's almost certain that for most of connected care, particularly the outpatient side, it will reside in part on a cell phone, and that'll be the patient's interface. And it probably will be part of the interface for the providers as well. That said, we can't have ICU rounds for the family practitioner that comes in the morning who's got 40 patients for the day and has a list of emails or texts about alarms overnight. That's not going to work. We've got to create it and bundle it in a way that is human factors friendly and helps workflow to keep us at the bedside where we need to be.
This is all really fascinating, Sam. My mind's going in, several different directions. On the inpatient side, when we were talking a lot about COVID and some of the critical care, not being able to go into the rooms, being able to do things remotely, how does that all factor into this?
One of our big goals in our patient monitoring business is to untether the patient, which I know for anesthesia providers is probably a really nice thought. For intensive care providers who help to untangle things when patients come from the OR, it's a very nice thought as well. But untethering the patient is really a key part of this. Untethering the patient is better patient satisfaction, which is probably better compliance. and it's less reluctance to stay in a monitored environment because it's cumbersome. So we think there's leverage there to really create a positive effect of monitoring. Now, when you put that kind of connectivity in the hospital and you untether the patient, you've got a lot of other options that could help workflow. For example, if you had some sort of a wearable device that is connected to the hospital network, when you wheel that patient into the operating room, that device should be able to say, Sam entered the operating room at 09:03 and he left at 09:51. That's a tiny little way you could help workflow, but that adds up, doesn't it? That adds up to all those paper touches or keyboard touches that we have the opportunity to really help, to keep us focused on what's in front of us, the patient, and not what's over here, which we all do, right? That looks familiar, doesn't it? That's not a help. That's not helping workflow. So I think that is the most important opportunity to work with providers at the bedside, understand workflow very, very well, and use this new tech to help drive improvements in workflow, while of course providing the same, medical grade monitoring standards that we're all used to at the bedside. We can't compromise on our medical grade standards inside the hospital or in the outpatient setting as well.
One of the things that I always feel is lacking, just the continuity of care. There's really kind of the lack. And that's where, when you were saying, not just like the charting thing, but just to know like the continuity of what's happening, because even if you have electronic medical records, it's still really hard to have that information kind of all in, at your fingertips, really. It
is really hard. And as much as an intensivist, I really liked the EMR from a surveillance standpoint.
Yeah.
I can snap into any room in the hospital, look at a patient's data, look at their images and labs without leaving the ICU. That was a big step forward for me as an intensivist. On the OR side, and we ran a large sedation service under our anesthesia department, I found the EMR to be kind of cumbersome. I missed the little piece of paper, the pink piece of paper. I could always catch up and always focus on my patient. And with the EMR, I felt distracted sometimes. So again, the importance of workflow, right?
Yeah.
The importance of really focusing on making our workflow better, which means we're at the bedside more, caring for that patient more. We're not going to miss something because we're turning away. So we have the opportunity to connect these devices in ways that aren't out there now. But these opportunities are only had by working with providers like those at the conference to understand what is really hanging you up here and how could a device help you.
The eyes on bit, Sam, do you think we're there from the point of view of being able to get eyes on without all the challenges of not having snooping cameras everywhere? But, because being able to see a patient is a big component of rapid evaluation of how sick they look.
Yeah, absolutely. Unfortunately, right now, cameras are a big part of connecting people that are caring for huge amounts of patients in the hospital. I do think, though, that as devices evolve and the suite of parameters coming out of them evolve into predictive algorithms, and this is already happening, we might not need that visual as much as possible. Because, Monty, if we're doing our jobs right as a device maker, working with partners like you and your groups, we're going to be able to action earlier. So hopefully will not need that picture to know, oh goodness, I've got to run and intubate this patient right now. Hopefully the information we're going to get is so much earlier that face-to-face, if it has to happen, we still have time.
So if I repackage that, you'll be able to tell me that I look sick without looking at me, if you see what I mean. You'll be able to
that's correct.
Say, Monty, you look sick based on the variables that I've acquired.
Yeah, and it's going to be a paradigm shift for the way we practice, right? The way we practice now is look, listen, feel, talk. And that could be shifted substantially if you're an intensivist and you get a warning, an earlier warning signal from a floor patient that they're trending towards sepsis. You go look at them and they may look just absolutely fine. And they may not have any of the usual and customary vital sign changes that we associate with early sepsis, for example. So we're going to have a shift in the phase of care that we make decisions in, and it'll be largely based on data and customized data for that individual patient. Then, oh my goodness, your cap refill's 8 seconds and your pulse pressure is a little wide. I'd argue that in a septic situation, that's a late phase. And as we look at really multiple parameter data coming in on patients with various pathologies, there are early trends that happen before we are aware. And this is well borne out in some of the data that was published during COVID, even over-the-counter watches with heart rate variability were able to predict with greater than 50% accuracy when that person was going to become symptomatic. So clearly we've got to get better there and close that gap and be more, positive predictive value, if you will. But that's the trend. That is the absolute trend. And it makes sense because if we're going to move patients out of the hospital and have them be sicker, we have less of a margin while we're examining them.
I want to throw 2 rocks in the pool, which I think are actually pebbles. One of them is the pushback that says there's still a massive community of people that aren't tech savvy and won't engage. And I kind of think we're over that. I think irrespective in our worlds, I think we're pretty much over, certainly in the United Kingdom, whether it be age or other inhibiting factors, that access to some form of digital communication device and how to interact with it is there. So I think that's still a pebble, but it's not a rock. The second one is the people who start spooking everyone to say, there's people out there, nasty people stealing your data and selling it to Martians to make millions. And you mustn't share your data with anyone because it's going to hurt you.
Yeah. So Pebble 1 is design and human factors and understanding the market of patients that are going to use this. And it's the same thing that we look at when we design for workflow improvement. We have to design for usability, whether it's an ICU nurse or an OR nurse, a surgeon, or my mother at home with a wearable application. It's got to make it work. Otherwise, what do? We as hospital systems find out it didn't really work so well in the 80-year-olds. Let's hire a couple of people to go take care of that, right? That's our model. We always try to fix it ourselves. So we've got to design for ease of use. And you'll see that as the next phase of devices comes out, you'll be very pleased to see, hopefully, that everyone can use them. But you're right, that problem will become less and less of a problem over time because of tech adoption. The second issue is data privacy, and it is a big one. Absolutely. We know all of our national regulatory bodies and governments have strict data privacy and rules, and we're committed as Medtronic to keep all of our data, whether it's from a pacemaker, from a glucose pump, an insulin pump, or any other device, absolutely and exquisitely compliant to all of those local and global regulations. So first and foremost, design is, again, very, very critical there. It's got to be designed with cyber issues addressed early in the design. It's got to be kept private. The benefits of having your data processed is that you will get your own fingerprint of what you look like physiologically. And right now, we don't do that. It's, well, hi, we're going to do your case today. I don't know what your blood pressure generally runs. I take a guess. I can look at the chart. But basically, we lump everybody into a box of what normal is. And that was fine when we did all those studies years and decades ago. Now, when we go to medical grade technology that's bringing us lots of data, we're going to really, I think, realize that each person has their own fingerprint of what vital signs are. That'll allow us to manage anesthetics better. That'll allow us to connect them to their providers better and manage outpatient, say, blood pressure or other outpatient medical conditions with more data than we've ever had. But privacy is key, and it is something that we take extremely seriously.
Yeah, that was a great question, Monty. Sam, I love this concept of refinement because, there is a bit of crudeness that we have had in medicine for a long time. Explain to me about, and you kind of touched on it just a little bit, about the perioperative patient. So someone that comes in, walk through how connected care really works with that patient.
Yeah, so connected care I think of it as extending the window of perioperative assessment and opportunity. Again, without creating workflow. So let's say we have a magic unicorn device that can collect a lot of data on patients' vital signs, can be worn for a week preoperatively, and that device could give you a customized preoperative report, okay? Not blood pressures and heart rates every 5 minutes, but a real snapshot, say hourly or whatever interval you want, to look at where is this person's baseline really. Then you could integrate that with their prior anesthetic history. And so you've got, when they walk in the room, instead of look, listen, feel, talk, you've literally got a 5-day, 4-day, 3-day, 1 week, whatever you want, window of analysis. And what happens over time is, as an anesthesia practitioner, you're going to look at patients differently. It's like you do the same case over and over on a patient. Let's say it's burn dressing changes in the burn unit, and you just happen to do it, 20 out of 25 days because of schedule. You know that patient really well, and you know exactly where they start and what happens when they get their meds. And you're not going to give that one again because they bottomed out. You'll use this instead. So we're already refining our techniques. It's just a lot more difficult when you're in an ambulatory surgery center and you have 10 cases and you've got to get going really fast and you've got to get them all home by the end of the day. So what we think is that by presenting that data in a way that's usable and packaged in a very easily assimilated manner, that can help preoperative evaluation. It could also come to you before that decision of go, no go that morning happens. You could pick up things that potentially you wouldn't have seen before. Oh, when this guy goes to sleep, his blood pressure skyrockets, or whatever the case may be. So we're going to open windows that we've never been able to look through before. And with that data, we think we can make much better decisions.
Well, that's been, so the intention of this or how it would look, interfacing with our electronic medical records that we currently have? I mean, is it another device that we have to have? How does that work?
No, I think absolute necessity is for us as a medical device company, a monitoring company, to connect to our electronic medical records. Mm-hmm. It's absolute necessity when we go back to workflow, and workflow is a big part of this. If, as you said, Desiree, if we're asking you to get another box, or we're asking you to hire another person, or get more rooms in your clinic, or whatever the case may be, it's not going to be as valuable as if we come to the table with workflow solutions that keep us at the bedside. That's the next generation of monitoring. And it's very exciting, and it's going to transform the way we care for patients. And instead of punching in a bunch of limits and listening for bells and looking and deciding, we're going to action earlier. But also, why couldn't devices like this, when a patient comes into the preoperative clinic, why can't that device let the hospital know that they're there, and their data populates automatically? And when they roll into the OR, everything populates. You still do your timeouts and everything, but why do we have to do 12 clicks to add Monty to the room from the list of patients in holding that, right? I mean, just right there, to think about all of our clicks we could prevent with the right tech.
Days of work.
Days of clicking. So, I do think that EMR connectivity is vital. In the United States, we have 2 main providers. It can be cumbersome to get through firewalls with new technology, but they're both receptive to obviously the same mission that we have, excellence in patient care. So I think that solution is very realistic, but it is absolutely table stakes to have devices like this.
Yeah. One more question when it comes to the perioperative patient, we'll move on. And Monty and I have talked a lot about this is, we have seen the transition of patients from hospital to ambulatory center. We're pushing the limits on the acuity of these patients. I really see, high value in being able to move our patients, through the system and throughput with this.
Yeah, you're exactly right. Not only in ambulatory surgery centers, but in the hospital too. Yeah. We take patients, when you think about it, they're in recovery or at an ASC and they're monitored, right? They're fully monitored. And then we say, all right, time to go, Monty. Everything comes off and out they go. And what we call this in our business is a monitoring cliff. It's a cliff that now we go to monitoring with call us if you have this or that or whatever. We use a phone and their own system. So to have a device that can monitor them, connect them, but not create workflow for the surgeon or the anesthesiologist all night long who needs to work the next day is key. So it's about safety, it's about data, and it's about how to handle that data. But you're exactly right. You've got patients that have more comorbidities than ever, many of which have tough airways that you're just used to handling every day because it's just normal. And out they go. So it's remarkable that we do as well as we do with so little monitoring. I will suggest, and actually I will say that we'll do better when we have a monitoring solution at home, the right monitoring solution. And I think you'll see that kind of tech coming.
And if I may say, the right technology for home is the right technology for the floor before you go home, isn't it?
No, absolutely. If you're on the floor, and I would argue that
it's not as safe as home.
The floor is not as safe as home. So, we look at the hospital at home data, and we look at, what Hopkins has done and many other providers. It's clearly safer for almost every metric you look at. It moves the needle meaningfully for readmissions, and we're going to see, preventing readmissions now is a good thing, but preventing admissions is even more important. But you're right, Monty, that same kind of device could be used on our med-surg floors. And we have a staircase of monitoring. We go from the OR to the unit, to the step down, to the floor, and then the big cliff to home. And almost everyone, at least in the US, is monitored in some way before they leave the hospital, just because of liability and standard practice. It's rare to see you walking around the hospital in the US without any monitoring on, unless they're about to leave. So we know that it's a critical component of patient safety in the hospital. So you're right, that could extend through the med-surg environment. Absolutely. But home environment post-operatively is really important.
What's holding us back at the moment, Sam?
What's holding us back? So, in a global position, that what holds us back here depends on what region we're in. So, in the US, we're still very DRG focused and very margin focused, get the patient through the system as quickly as possible. And unfortunately, there's not a lot of reimbursement in the home monitoring environment. That has not stopped many, many very forward-thinking systems in the US investing in it anyway, in a very creative way, realizing we're not going to get revenue from this group of patients, but we are going to realize better life for them, keeping them out of the hospital, keeping them at work, keeping them happy at home, and we'll save a lot of money on the other side because they cost the system a lot when they get readmitted. So revenue is part of it. And I think we're going to see more forward-looking leaders of medical systems understand that even though the revenue may not be there, I can't bill for that service right now. It's a valuable service to my patients and to my medical staff and to running the hospital as effectively as I can. So I think that will overcome. And I think we'll see revenue in the US and other similar markets come as the complexity of care develops, the infrastructure with devices develops, and then revenue will come. There is already discussions within subcommittees in CMS in the US to help reimbursement for this kind of care. So it will come over time. In other parts of the world, it's different reasons why it hasn't been adopted yet. One big reason is the failure to improve workflow. If a device creates more work, even if it's amazing in what it does, it's not going to be taken up because all of us are already overworked. All of us already doing more than we did a year ago, right? A month ago sometimes. So we've got to have devices that improve workflow. And then I think, other issues in the rest of the world, the balance of inpatient and outpatient care can be very different. In the UK, for example, in the US, we're focused on keeping people out. In other nations, length of stay is not an issue. The reimbursement structures are very different. So the need for a home solution, say in Japan, may not be there for decades to come. We'll just have to see. length of stay is very long in Japan, and that's a tradition and a function of their economic healthcare system. So it depends from place to place. Monty, you've done a lot of work in Africa. We think about emerging markets. We've got to think about this kind of tech helping monitoring in hospitals that currently have nothing, right? They have blood pressure on a stick and they go from bed to bed, taking vital signs the old way. And you have a flow chart with vitals Q6. We've got to do better than that, right? And if we can find affordable tech for emerging markets, that provides the foundation on which other care can happen. It's kind of hard to develop a surgical program in a rural hospital in Africa, even general surgical, if you don't have monitoring on a med-surg floor. So looking at the emerging markets as well, and really trying to find solutions like this that can escalate patient safety within those hospitals, empower clinicians to develop new therapeutic lines for their patients, and make sure that patients are connected and supported.
Brilliant answers. My second quick question, because I think Desiree is going to come to the future in a second before we close, is what can, it's not a loaded question, I'm just sitting here now saying, what can Medtronic do to help me today, tomorrow? Where are you with regards to an offering for me to turn around and say, that says great, I'll have one of those?
Medtronic, we're the largest medical device company in the world. And one of the things that characterize us is exhaustive dedication to innovation. And that's within our own company and in other partners outside of it. And I'll tell you, the tech is coming. Much of it is already out there in commercial grade things. We're not interested in the commercial space, the fitness space and wellness space. We're committed to medical grade, high-level decision-making devices that will not undermine our confidence as caregivers one bit, whether that person's at home or whether they're in the ICU. So those devices are on the horizon. And I think that we'll see a transformation in healthcare coming in the not too distant future.
It sounds as though this is the sort of early days of Apple, and you're telling me a cool iPhone's going to come along soon, but you can't buy one today. Is that?
I love analogies, and I often come up with some of the worst analogies ever. but the way I have tried to explain this tech revolution to other colleagues around the company and other physicians and nurses is that think back when you had that flip phone, that Motorola Razr, and you loved it. You loved it. And along came this iPhone 1, and you were like, that's never going to catch on. Well, what's coming in patient monitoring is that type of a revolution. And so it's really fun to be a small part of this revolution, because we've got to manage for today while thinking about these capabilities as they evolve very, very quickly. Sensing technology, algorithms, human factors for the devices, connectivity. This is a freight train of innovation right now globally, and we're a big part of it. We'll always be a big part of it because we're committed to patient safety, and monitoring is the cornerstone of safety. But yes, it's a good analogy. What do I need an iPhone for? What do we all carry right now? We're all carrying some sort of phone like that, iPhone or an Android.
Smartphone.
Yeah.
I love this. Is so exciting, Sam. We could continue to talk about this all day, but just tell us, what is the future? Where do you see us in the next couple of years to the next 5 years or so?
Once we providers have the tech that can support patients in the outpatient environment, post-operatively, pre-operatively, post-hospital discharge, I think we'll see a revolution that transforms the outpatient space. And we'll see people with chronic conditions that are frequent flyers in the hospital. We'll see them not get admitted at all in a year. We'll see the ability to partner with pharma to help make sure that people are getting their medicines through monitoring and connectivity. We'll be able to understand better what each patient is doing. Think about the transformation in cancer care with genetic analysis of tumors and targeted drugs. That sort of pharmacogenomics, I like to think where we're heading in medicine is sort of device interface with genomics, understanding your particular fingerprint and your particular response to things. So I think this is the initial steps that we'll see in the next couple of years. I think down the line, we will see really advanced early decision-making that is utterly transformative, keeping patients out of the hospital and keeping us well. I think the COVID pandemic ignited a telemedicine, I won't say revolution, but certainly the awareness that I can provide care to someone with a pulse ox from Amazon in their house on oxygen.
Yeah.
I may not like it, but I can do it. So we flexed our tele muscles during the pandemic, really, in many ways. What we've got to do is improve on that platform and listen. We, the device companies, have to listen to our providers. How can we best help you constantly as that evolution continues? And we're committed to staying connected to folks like you and many, many other specialties all around the world to make the best devices possible.
Yeah.
When you're speaking there, sorry, Desiree, speaking there, Sam, it sounds like we've got a new omic coming our way. I'm not sure what it is at the moment. I'm sure we'll have it by Friday. We've had genomics, epigenomics, metabolomics. Maybe it's pathophysiolomics or something.
We've got to think of that, Monty. I'll put you on that. Definitely. We definitely have to come
Sorry,
up.
Desiree. Sorry.
I'm going to let you guys
handle
that one.
We're digressing.
Physiomics. There we go.
Yeah. This is absolutely fascinating, Sam. Thank you so much for sharing this and sharing the vision and what we have to look forward to. It's really exciting, especially for many of us here that are listening today who are probably early adopters or at least, kind of love to be in this space. So I think it's great and can't wait to hear more about it. I love that you said that you're always wanting to hear from us as providers. And I think that there is sometimes a little bit of lack of that we all kind of put up our walls, but to really make it better for our patients, we have to have great conversation with our partners in industry. So what our needs are, just like you said, you want to improve workflow.
Absolutely. Our business success, which is helping patients, same as our business at the bedside, depends on being connected to the way you, the providers, do your work and how we can improve it. I mean, if we walk into an OR now, a cardiac OR in the US today, or really any developed country, there are boxes everywhere, right? And it's partly our fault as practitioners. We've accepted it. And now, though, Monty brings up a good point. We've all got smartphones. Why don't we have a customized giant monitor where we can grab and put on what we want for a given case? Or better yet, why can't it say, Desiree, the last time Sam was in here, this is what you had up there. Is this what you like this time? And you say maybe yes or no, and you control it with your voice, or we've got to push the envelope, but we're only going to do that effectively if we work together. So we're very committed, particularly in our patient monitoring business and respiratory interventions, to connecting to groups of key individuals. And that includes nurses. Nurses are a huge part of our monitoring business. In fact, physicians touch our monitors much less than our nursing colleagues do. So we're really investing in understanding human factors from a nursing workflow standpoint. And that includes workflow in the OR.
Sam, thank you so much for your time. I really appreciate it. We on Top Med talked to you, and I'm so glad that we could have this conversation during the World Congress of Perioperative Medicine. I think it's really super important.
Top Med Talk.
So hopefully we can catch up with you again in the coming year and hear more about some of the exciting news coming out. That'll be fantastic. And thank you for listening and watching Top Med Talk. You can always find us on your favorite social media platform, and we're at topmedtalk.com. All of our content is actually going to be on our platform, right, Monty, the EBPOM platform?
Absolutely. It'll all be there. So for the whole world. And just to note, as we say that, because this is a World Congress, thank you, when you were talking to what will happen in the future, Sam, to recognize that there's a big complex world out there that has different resources and different needs. So thank you for that.
No, you're very welcome. Thank you both for having me on. And I hope everyone enjoys the conference, and hope to see you all soon.